Thank you very much, my good friend. And indeed, it's a real pleasure to be here. The topic is very important, and I think deserves much more attention than we do today. But it's definitely not easy. Definitely not easy because this is really a silent threat. That's the title of my talk. I didn't choose it, but I like it. I think it's a very good title. And can we recognize GI dysfunction? I think the answer is yes and no. Yes, of course, as good clinicians, we could identify a number of signs and symptoms, perhaps even measure some elements, but not many. But it's not very precise. And therefore, we don't do it well, actually. Of course, we all have a conflict of interest here. We'd like to thank Nestlé. We received honoraria for these presentations. As we just heard, the gut has a very important role. Dysbiosis, altered epithelial function, increased gut permeability, translocation of bacteria and their products, impaired gut immunity, altered splanchnic perfusion. These are all very important elements. I will not have too much time to speak about dysbiosis because it's a topic by itself, especially if we speak about the microbiome. But this paper just came out, and it's a very good review in the Current Opinion. I am editor-in-chief of this journal. And it's very complex because we could speak about evenness, about diversity, about abundance. So there are different characteristics that could play an important role. And we know that we are just in the early stages of understanding the importance of the microbiome. Now, the other elements are somewhat intertwined. We speak about altered gut function associated with some reduced splanchnic perfusion in many conditions, and also the important role the gut plays in the immune response of the body. So, yeah, there is a complex interaction between the gut and all the other organs. If we think about it, that could be a talk by itself, to speak about the relation with the lung, with the brain, with the kidneys, etc. And that's how some people had this very important saying many years ago: the gut is a motor of multiple organ failure. So, as practicing clinicians, we should ask, what are the implications? And the first implication, as reviewed in this very recent paper, just published, is nutrition. That's the best thing we could do for the gut, to maintain its function, to maintain the flow, actually, with nutrition. Of course, we increase the flow going to the gut. And we could speak about probiotics, fecal microbiota transplantation, but we know that these things are very controversial, and we spoke about it this meeting and at many other meetings. And there are investigational strategies. But so what remains first is nutrition. And of course, when I was a young intensivist, we were saying, if the patient does not tolerate enteral feeding, you just go for parenteral nutrition and you are sure that everything is in the veins. But we reassessed it, not only because there are some risks associated with parenteral nutrition, but also because enteral nutrition plays a major role in maintaining gut function. So we agree that enteral nutrition should be preferred to parenteral nutrition to maintain gut function and also to avoid other risks associated with parenteral nutrition. So the recent guidelines here with a number of experts, some of them being in the room, The guidelines say that we should start low-dose enteral nutrition within 48 hours of ICU admission. What about patients in shock? Can I do that? Isn't there a risk of ischemia, bowel ischemia? Well, we can delay enteral nutrition in patients with shock, except perhaps if the vasopressor agents are administered in small, moderate doses. In patients requiring vasopressor agents, enteral nutrition should be started with gradual advancement, with monitoring for symptoms and signs of GI intolerance or unexplained worsening hemodynamic status. So it's some kind of yes and no, yes or no type of answer. Yeah, perhaps it's better to avoid it, but you can still do it, but prudently. And it shows again that we need to individualize our therapies, which is, of course, a theme that I always like to reinforce. So the question 10 in this paper was how to address GI intolerance. Well, it's usually with gastric residual volumes, GRVs. That's how we look at how much nutrition remains in the stomach. Of course, it's a marker of disease severity, but today it's a bit conflictual. Some people say we should not use it routinely, especially after a large study showing that it may not have a significant impact on outcome. Okay, that's not my topic. I will only go back to something we proposed, Jean-Charles Prézère and I, in the Lancet, well, 10 years ago, more than 10 years ago. But I think it's still valuable. It's still valid. If we can, we start enteral nutrition, maybe not in patients who will be starved for only a couple of days, but otherwise we would try to use the gut. Yeah. And if there is no good tolerance, after a few days we will start the parenteral nutrition. That's what we currently do. It's not a very precise recommendation, but that's what it is. It's also important to think at the splanchnic perfusion. When we think about it, almost 30% of our cardiac output goes to the splanchnic circulation. Wow! That's a large part of it, much more than the brain. And we must keep in mind that if we are in trouble, the first goal in life is to cope with bleeding. Our body reacts as if we had been hit by another animal and if we were bleeding, or if we had been traumatized for other reasons and we are bleeding. What happens then? We need to think at what we will do. So we need to preserve cerebral blood flow. We need to keep enough blood going to the heart to pump enough blood so the coronary blood flow is relatively preserved. But where can we get this blood? Well, we go in the splanchnic circulation. That's how when we are under stress, we are not hungry, we may have a little bit of diarrhea, we may have abdominal cramps before an exam when we are not ready for this exam. And of course, we need to reduce renal blood flow. That's smart. Because if we bleed, we don't want to urinate. We want to keep our volume. So that's the redistribution of blood flow. We need to think about it. And when we think at the various adrenergic agents, there is a risk of decreasing blood flow with vasopressors. Remember, we tried dopamine years ago with the idea that the dopaminergic receptors, which are vasodilating, are present more in the splanchnic circulation and in the renal circulation than elsewhere. So these are the dopaminergic effects of low-dose dopamine. Unfortunately, it didn't work very well in terms of patients' outcome. And with Daniel De Backer, when we did this prospective randomized control trial, we found that there was really no place for dopamine. Okay? So we have no good option to increase hepatosplanchnic blood flow. Certainly not vasopressin. Of course, vasopressin decreases hepatosplanchnic blood flow. It's a very interesting molecule but don't use it for the gut. So, at the end, we are left with primarily beta-adrenergic agents, dobutamine, if we want to increase blood flow. But how will this be guided? That's not so easy. How can we assess GI dysfunction? Let's look at this recent paper, again with experts being among the authors. You can read it. Abdominal distension, bowel dilatation, abdominal pressure, abdominal pain, stool passage, vomiting. That's how we assess GI function, right? Not very precise. Not very objective. So, we need some markers. And unfortunately, we don't have them. Citrulline is perhaps the marker at the top of the list, but it's not very good, not very reliable, no. So when we developed the SOFA score to describe organ dysfunction, when I was president of the European Society many years ago, we ultimately quantified the degree of organ dysfunction for 6 organs. We know that. And indeed, we wanted to have objective variables that we can easily measure everywhere. And there was a group in our working group. There was one group working on GI dysfunction. They came back and they said, sorry, we cannot propose anything. So that's the SOFA score with the 6 organs you know well, but there is nothing in GI dysfunction. So as you know, we are now in the process of revisiting the SOFA score. Okay, to add maybe vasopressin, to add maybe ECMO. Okay, I'm not sure these will be major changes, but in this process, we could not really better assess GI dysfunction. We are back to the same elements there. You could say, well, you can measure intra-abdominal pressure, that's important, instead of just saying that there is distension. Yeah. This has been known since 1947, before I was born, much before I was born. But the compartment syndrome is an interesting concept. But of course, the intra-abdominal pressure that we can measure quite easily, yes, indeed, Manneken Piss knows it well, it will concern a minority of patients, let's admit it. And then if the patient is treated like this, the abdominal pressure will go down, or like this, the abdominal pressure will go down. So, no, does not really work. Can we propose something else? When I was young, we were interested in gastric tonometry. You know, I spoke about it in this room 2 days ago. It's a modified nasogastric tube enabling to have some measurement of the oxygenation of the gastric mucosa. Oh, that's important. Oh, that's very, very important. And we had one study from South America published in The Lancet in 1992 showing that there could be a reduction in mortality if we try to maintain this pHi, the intramucosal pH, above a given value. Interesting. Yeah. No. Because there were too many artifacts. And especially feeding. Feeding was disturbing the measurement. So we threw it away. Unfortunately, we have no good variable to assess GI function. So, in summary, again, go back to these recent reviews here with Dr. Bachmann. You can read it, the clinical symptoms and signs, abdominal distension, absence of stool passage, abdominal pain, diarrhea, maybe GI bleeding if you want to include it there. Then we have the measurements, not much, and then you have the entities that could describe these abnormalities. It's very difficult to come up with a real score. So the clinical assessment remains the main tool, And a single sign and symptom does not reflect GI dysfunction adequately. So we need a set of variables, and even then, it's difficult to quantify it. So studies are warranted to develop tools reflecting GI motility, and biomarkers for response to enteral nutrients, including absorption. But right now, our approach is still very clinical, and the important element, again, is to try enteral feeding to protect the gut. Thank you very much.
Terrific. Thank you for this very, very nice presentation, Jean-Louis.